Hi, my name is Michael Dolinger. I'm the Advanced Pediatric Inflammatory Bowel Disease Fellow at the Icahn School of Medicine at Mount Sinai, and I'm going to talk to you about our recently published article in IBD Journal, Dual Biologic and Small Molecule Therapy for the Treatment of Refractory Pediatric Inflammatory Bowel Disease. First, I wanted to start with why we did the study and why it's so important. Right now, the only approved biologic therapies for children with inflammatory bowel disease are anti-TNF therapies, Remicade and Humira. And while they're effective for many children with inflammatory bowel disease, there's only a sustained durable remission rate of approximately 40%. And when you take that and combine it with those who are primary non-responders, that leaves children with limited options for additional therapies to control their inflammation. We have extensive use showing vedolizumab and ustekinumab to be effective for children with refractory disease to anti-TNF therapies. However, those are still not FDA approved for use in pediatric IBD. Then we have the recent use of tofacitinib, a small molecule therapy for pediatric inflammatory bowel disease, in which we have even less experience with. So now you have about half of children who don't respond to anti-TNF therapies, who need additional treatment, who go on to ustekinumab, who go on to vedolizumab, and some who go on to tofacitinib. And those only have response rates of about half or less. And so now you have a significant portion of children with inflammatory bowel disease without an effective steroid-sparing therapeutic option. And that's why we wanted to look at combining biologic and small molecule or dual biologic therapy for the treatment of refractory pediatric inflammatory bowel disease. So what we did is we took 16 patients children less than 18 years old, who were refractory. And what that means is that they had failed at least 2 biologic therapies, either 2 anti-TNF therapies or an anti-TNF and vedolizumab or ustekinumab. And those patients, the majority of which were on steroids. And so we had 16 patients in which we used combination therapy. The most common combination therapy was vedolizumab and tofacitinib, in which we used 9 children were treated with that. 4 children were treated with ustekinumab and vedolizumab. 3 children were treated with ustekinumab and tofacitinib. And what we saw was an amazing clinical response in this previously refractory cohort. They had never achieved steroid-free clinical remission in a median of 3 years before combination therapy. And within 6 months, a median of 88 days, so very fast acting, we had steroid-free clinical remission rate of 75%, an amazing response for these children. And at 6 months, you get this incredible steroid-free remission rate for children for years have been accruing bowel damage and have never been able to achieve the way they're feeling. So incredible response for dual biologic therapy. We had improvement in inflammatory markers. So overall, for our kids, we were able to show that this is an effective option for those who had previously been refractory and those who could not get off steroids. This is a shared decision you have to make together with patients. And so it's important to understand the safety of what you're doing. We looked at the safety outcomes. And while we did have excellent safety for the majority of patients, we did have one serious adverse event in a child who was treated with vedolizumab, tofacitinib, and high-dose steroids who developed septic arthritis of the right knee and then a DVT. And so you really have to be, careful when you're doing these therapies, as we did have that one event. So if I could summarize overall, is that this is a study of pediatric inflammatory bowel disease patients who were previously refractory to multiple biologic therapies, unable to come off steroids, who were started on combination therapy with either 2 biologic therapies or a biologic and small molecule. And they were able to have an excellent clinical response rate that was maintained to 6 months with limited safety signal. And so you really have to make a decision with your patients about effective therapies and the safety, and use that to guide your treatment. And what this study can do is this study can serve to fuel and provide data for future studies and bigger studies for combination therapies in both adults and pediatric inflammatory bowel disease, where data is still extremely limited, but can help us break through that therapeutic ceiling that we're all struggling to get through.